Hello, I'm Praneeta Konduri. I'm a postdoc at the Amsterdam University Medical Center. Today, I will talk about modeling tissue damage during an acute ischemic stroke. An acute ischemic stroke occurs due to the sudden blockage of one of the cerebral arteries due to an occlusion or a thrombus. This leads to the formation of an infarct or a lesion. Understanding the mechanisms involved in lesion formation is very crucial in patient management and also in treatment development. But to understand the formation of the lesion, it is first important to understand the mechanisms involved in tissue perfusion. Unfortunately, predicting tissue perfusion is not so trivial. The work packages 2 and 5 within the INSIST consortium have been studying and simulating the mechanisms involved in tissue perfusion, and I will give you a brief overview of our major findings. To start with, we tried to simulate the blood flow from the heart to the brain, and for this, we modeled the blood vessels as using a 1D blood flow model. For this, the large arteries ranging from the heart to the brain were modeled as one-dimensional elastic network of vessels. We also accounted for the circle of Willis, which is a very crucial collateral pathway which is responsible for supplying blood in the brain. This model of the blood flow feeds into the brain tissue model. The brain tissue is modeled as a tetrahedral mesh, which can differentiate between the ventricles and, of course, also the gray and the white matter. But the idea is to adjust this to a virtual patient. For this, we first combine the blood flow model with the tissue model, as you can see here, and then we make this more patient-specific. To make the blood flow and the tissue model patient-specific, we first account for the blood pressure of the patient. This changes the blood flow within the patient, and the brain perfusion is affected accordingly. The 1D blood flow is simulated using the blood pressure of the patient, and the 3D perfusion model is coupled to this and using a fine transformation adjusted to fit the patient's brain. So in the end, what we have is a patient-specific blood flow and a brain parenchyma. This model can also be used to simulate an occlusion. This is done by blocking the blood flow through one of the cerebral arteries. What you see on the left here is a healthy state, and on the right is the state due to the formation of an infarct due to an occlusion in one of the arteries. This is modeled using a decrease in the blood flow due to a decrease in the blood pressure due to the presence of an occlusion. Another important factor to account for is collateral circulation. Collaterals are alternate pathways that connect the major arteries in the brain, and these allow to maintain blood flow in the event of an occlusion. In our model, we also account for collateral circulation, as you see on the right here, by connecting vessels based on the proximity of their presence. Further on, you see here how the tissue perfusion is affected based on the grade of the collaterals. This grade is what is used currently in clinical practice, and it's a 4-point grade that goes from absent collaterals to very good collaterals. And what you see here is the tissue perfusion or the cerebral blood flow that is affected by the presence of the collaterals. This in turn can be used to model the infarct. What you see here are simulations that are on how the collaterals influence the formation of infarct. So on the left here, in a patient which has very bad collaterals, the infarct keeps on progressing. However, on the right, the collaterals allow to sustain the presence of the infarct. In our pipeline, we also model the presence of how the treatment influences the infarct. So when the treatment goes really bad, so the vessel doesn't recanalize at all, what we have is basically the scenario on the left, that the infarct keeps on progressing to the downstream territory. But in case the treatment is completely successful, the vessel reopens and the blood flow to the downstream territory is secured again. However, in clinical practice, it's not that straightforward, and there are also what is called thrombus fragmentation. So when the treatment is, which leads to the formation of microemboli. In our INSIST pipeline, we also try to study microembolisation and microcirculation. So we performed experimental work on microembolization using rat models. What we did is mimic microembolization by injecting thousands of plastic microspheres ranging from 15 to 50 micrometers into the internal carotid artery of a rat model. We then found multiple lesions near the downstream territory, which represent the hypoxia, ischemia, and also infarction. What we were then interested to see is how the how these hypoxia and infarction are related to the location of the microspheres. And we found a correlation between the location of the microsphere and the hypoxic regions in the order of 1500 micrometers. Furthermore, we studied how the hypoxic and the infarcted regions grow as due to the presence of the microspheres, and found that with time, the microspheres are extravasated from the brain parenchyma. We also studied the process of microembolization using the principles of microcirculation. What you see on the left here is a simulated capillary network, but more on the microcirculation level, and on the healthy state, what the circulation looks like based on the partial oxygen within the blood vessels. And on the right, you see the effect of microembolization on the partial oxygen. In summary, what we did in work package 5 and 2 is, first of all, study how tissue reacts to blood flow restrictions by modeling the blood flow and tissue perfusion, modeling infarct growth, and we also perform experimental and computational studies to study more microthrombi and microcirculation. But it's also important to validate our findings using clinical data. The first validation study we performed was using CT perfusion data to validate the tissue perfusion models. On the left here, you see the CT perfusion maps from a real patient. We tuned the virtual patient to mimic the same characteristics as the real patient, and we found comparable results between the blood flow from the clinical data and the virtual patient. Furthermore, we also validated the simulations of the infarct using an ischemic core atlas. The ischemic core atlas is based on clinical data from the Mr. Clean trial, and what we did is we segmented the infarcts from the follow-up non-contrast CT scans from all the follow-up patients from the Mr. Clean trial. We then registered them to an atlas, which has 56 delineated brain structures. So what we get then is a probability map of what the infarct can look like for different clinical characteristics. On the left here, you see what the probability of an infarct would be if you have if there is an occlusion in the ICA terminus, or on the right, a little bit more on the distal side. So you see that the probability of getting a larger infarct is of course reduced when you have a more distal occlusion. Such probability maps can be used to validate the simulations that are obtained from the in silico perfusion models. Furthermore, the ischemic core atlas was used to generate the percentage of the anatomical regions that are most influenced or most affected due to an occlusion, and we also made a graphical user interface that allows the user to select the kind of clinical characteristics that are of interest, and then it can generate such probability maps and also give the percentage of the most important anatomical regions that are affected. We also have studied how the infarct grows after treatment and identified that the infarct is in fact not stable, but it continues to grow after treatment. And this lesion growth is associated with an unfavorable functional outcome. And what is understood in literature is that what is growing could be part of dead tissue, edema, and also hemorrhage formation. So we also did further analysis to understand if we can differentiate between the contents of the lesion. So we quantified what edema looks like and how much percentage of the lesion is true infarct. And what we found is that it's eventually the growth of the edema that is more responsible for the unfavorable functional outcome. We believe that these clinical findings can be used to improve our in silico perfusion and infarct simulation to make them more patient or more realistic. I'd like to thank all the partners in the consortium who have assisted in the research. Thank you.